We're talking with Dr. Larry Tanenbaum here at RSNA 2010, and we were going to discuss some of the new MR perfusion techniques that you're going to share with us.
Good morning. MR perfusion's been around for a while, and frankly, I think it's an underappreciated technique. I think most folks are aware of the potential utilization in stroke, and I think in most practices it isn't used a lot. It's used at academic centers, but as MR becomes more and more important in the evaluation of stroke, and some of the more recent trials suggest that MR will be, I think more and more folks will be doing perfusion imaging, and familiarity with how to do the technique and how to process the technique I think is very important. For me, in day-to-day practice, the thing that I see most often is perfusion imaging and dynamic contrast-enhanced imaging for neoplastic evaluations. And that's really where I think it makes a big difference in day-to-day practice. I think we all see tumor cases, and particularly in the primary brain tumors, to do a routine exam without the use of perfusion techniques, at least first-pass perfusion, but also sometimes permeability imaging for the enhancing lesions is doing a very incomplete evaluation. Frankly, if I was going to be doing a primary tumor, I wouldn't bother to give contrast maybe more than once unless I was doing perfusion imaging. Now with perfusion imaging, we can differentiate between treatment changes, between radiation necrosis, even dural enhancement, differentiate those from residual tumor. And that's a very, very powerful tool to be able to key in a surgeon that, even though the images look floridly different, that this is probably treatment change or pseudo progression as opposed to real tumor progression. So we use that. Traditionally, perfusion techniques are based on dynamic susceptibility contrast. You inject an MR contrast agent quickly, you image over time, and these have their strengths and weaknesses. The strength takes about a minute. You're injecting the contrast anyway. Weaknesses are tendency towards artifact and distortion with these EPI-based techniques. Over the last couple of years, we now have an alternative for perfusion imaging that doesn't require the use of contrast, and that's usually based on arterial spin labeling. I think all of the manufacturers have some form of arterial spin labeling for perfusion imaging enabled on their system, and the one that I'm most familiar with is a 3D fast spin echo-based technique. And in our hands, the ASL, arterial spin labeling technique, actually outperforms the contrast-enhanced technique for a number of reasons. They don't have the artifacts, we don't need the contrast, and frankly, the images are easier to interpret, better dynamic range. And it's a lot easier to differentiate high blood flow areas from the lower blood flow areas. So we like that, and that has a lot of appeal for us. Any negatives? Yeah, it takes about 5 minutes. Any positives? You don't have to give the contrast agent and you don't have to process the data. So I think probably most practice sites that maybe shy away from advanced imaging because of the processing needs and the consistency of performance when you're processing may actually migrate towards the newer arterial spin labeling techniques. So very excited about that.